Hello out there in Cyberworld. Ed McLaren here with my Dental Raves and Occasional Rants team. I don't know if you can see them all on the screen. Dr. Miguel Ortiz, Richard Young, and Anvita Maharishi. We're going to all be contributing to this episode. I believe this is our fourth full episode. And we're going to do a little bit different format this time. We're going to start with the literature review and talk about one of the very hot and maybe contentious topics in prosthodontics today, or restorative dentistry, post or no post. When should we use a post? Should we not use a post? Should we never use a post? Should we always use a post? And everybody's going to give their experiences on this, but along with starting first with a little literature review, then we'll get into some of our dental raves, some of our likes and some of our dislikes. And then we'll finish off with an interview with one of our good colleagues. Everybody knows that's in our digital room today, Dr Alessandro Devigus from Zurich, Switzerland. So he'll be on with us a little bit later in the show, talking about his experiences, things he's done in education, private practice, and how he does or believes in dentistry today. So with that, let me reintroduce, I'm sure everybody remembers Dr. Anvita Maharishi, who's got more letters after her name than masters, working on PhDs, professors, all kinds of fun things. But anyway, so let's take it away, Anvita.
So welcome again to episode 4 of Dental Raves and Rants podcast. And today's topic is post or no post, ? This is a very interesting topic that I get asked about all the time in the student clinics. So we'll do a quick literature review about some of the evidence that's available. So I would like to start with a very good statement from this paper in 2003. So dentistry has moved from extension for prevention to prevention of extension. And that, I think, sticks with a lot of us with the change in the paradigm and the paradigm shift that we see in dentistry. A terminology, and Dr. McLaren knows I like using small abbreviations, so that the one that I'll be using again and again today would be ETT. And when we talk about ETT, this is not the extraterritorial I'm talking about, but I'm going to talk about the endodontically treated teeth today. So that's the ETT I'm referring to in all my slides. Just to go to the definition of feral, because in order to decide if a post is needed or not, we really need to talk about feral, and we cannot get away from that. So the Webster dictionary definition of feral is a ring or a cap, usually of metal, put around a slender shaft to strengthen or to prevent splitting. And this also comes from the plumbing industry, where actually the feral term generated and then was applied to dentistry. So what it means is a feral provides a sealed compressed fitting to prevent gas and water leaks on the plumbing system. And a plumbing feral is actually a type of cap widely used in pipe and fixture joints, as you can see in some of these images. And then it could be a double feral or a single feral, and front feral, back feral. So basically that's where it comes from the plumbing industry. And then how we apply that in dentistry is, so that's the dental definition from the Glossary of Prosthodontic Terms, GPT-9. It's defined as a band or a ring used to encompass the root or crown of a tooth. Or you can also define it as any short tube or bushing for making a tight joint. And then we all know the classic literature on feral effect, and we kind of learn and have hammered this feral term down as dental students all the time. So to understand how it impacts our restoration design, so feral design per Sorensen and Engelmann plastic paper seems to increase the fracture resistance of endodontically treated teeth, or ETT. And then this is in this picture. I don't think you can see my cursor, but the arrows point it to the overlapping of the crown and dentin, and that's the feral effect that we talk about in terms of dental restoration. So this is actually a nice picture that shows the tooth restoration interface, the overlapping of crown and dentin. And as per the study, like I said, feral design increased the resistance of ETTs. So again, going into some more literature about this, studies have reported a minimum of 1.5 to 2 millimeter of ferrule that is needed to improve fatigue resistance. But, however, this has been investigated for cemented PFM crowns with posts. So you have to pay attention to how the evidence came into being, and then the question comes up, does it still apply to the adhesive restorations that we do more and more in our practices today? So the RCTs that were done, they all showed better survival rates of ETTs with PFM crowns restored with post than without post. Again, the evidence was for PFM crowns with post. So is it still relevant for bonded edge ceramic restorations? So let's look at the evidence about that. Now, can we lose ferrule? Of course, we can lose ferrule by aggressive crown preps, by over-preparation of teeth to achieve retention or resistance form, and heavy shoulder margins, and as we popularly call them, as serial pulp killers, who do these kind of heavy shoulder preparations. And then some of the no-post approaches and alternative strategies we all know are surgical crown lengthening and orthodontic extrusion. But the problem is they are all time-consuming and do not produce results in a single restorative appointment. So what is the new postless restorative approach, which is the endocrown? That means using the pulp chamber as an extension of the crown itself. So the first published article, believe it or not, was in 1995. This is not new. It was originally called the monoblock technique. And then this is a very, again, old classic paper about how they utilized the inside of the pulp chamber to produce a monoblock restoration, and it was done for both anterior and posterior teeth, which was a single element ceramic restoration. So then we talk about what is internal ferrule or adhesive ferrule. So the internal walls of the pulp chamber can be used to bond the core buildup. And then this is without any intracanal retention, and Manier's group has done a lot of in vitro studies for the restoration of endodontically treated molars with or without ferrule, with adhesive core buildups, and we'll look into that evidence in the next few slides. So again, paper by Cavallo and Manier, accelerated fatigue resistance of endodontically treated incisors without ferrule, restored with CAD-CAM endocrowns. And in this paper, they talk about, they say the endocrowns do not fully compensate for the absence of ferrule. The ferrule effect outperforms all non-ferrule approaches, and the endocrowns perform superior to fiber post with composite buildups. And the post and core approach failed to increase fatigue resistance, and the post and core approach resulted in catastrophic root fractures. So this was the outcome of this study. So brings us to the same question, post or no post? And the other question I ask all my students is, what is the original purpose of the post? So the original purpose of a post is to retain the core and not to increase the intrinsic resistance of the root. So that's the myth that we all have, that somehow post is going to increase the fatigue resistance of the tooth, but in fact, it causes more vertical root fractures and terminal failure of the ETTs. And then, like I was saying earlier, the evidence, went too fast. So the evidence that talks about post-endodontic restorations and then endodontic post and core or no post at all, they say there is no unequivocal clinical evidence to support or reject the use of posts, even for no wall cavities, either for direct or for indirect restorations. A positive effect of post placement was shown by 4 out of 11 randomized controlled trials when no cavity wall was present. And then 3 additional clinical studies demonstrated no post effect. So the clinical evidence is actually lacking on the influence of tooth location in the dental arch on the survival of post-retained and post-free post-endodontic restorations. So that's what this review said. And then what comes first? Ferrule comes first, post is second. Is this true? So this is a very nice paper that talks about how to kind of analyze whether my ferrule is important or my post and core is important. So ferrule has a supportive effect on restorations, and most studies fail to show the post effect. So between ferrule and a post, ferrule always wins. And then this was another paper and a study done for CEREC endocrowns. Endocrowns were done in a single appointment using chairside CAD-CAM. And then the short-term survival rate of the CEREC endocrowns was actually 90 to 95%. Then, again, a series of papers, in vitro studies done by Manier and Carvalho group. They study about the influence of no ferrule, no post build-up design on the fatigue resistance of ETTs, and then restore them with the nanoceramic CAD-CAM crowns. And then they also investigate the adhesive core build-up designs on the resistance of ETTs with lithium disilicate CAD-CAM crowns. So very interesting 2 papers. And then this is a very good diagram that they show where they talk about the advantages of the adhesive core build-up. So then what they found in this study was 2 millimeter core buildup was more favorable. There was no added benefit of the 4 millimeter core buildup, and Dr. McLaren talks about that in his lectures as well. I know because I have heard him lecture for quite a while now, that you do not have to create that 4 millimeter of core to get that retention in an adhesive type of ceramic restoration. And we'll talk about that later in the talk today. And the limitation is the self-adhesive cement that showed no benefits for endocrown with no buildup, which was also part of the test study that this paper talks about. So then let's kind of do a take-home message. The ETT, endodontically treated teeth with ferrule. The question is, will the glass fiber post benefit when a tooth has ferrule? So I would like to answer that with another paper from Manier, which talks about ferrule effect dominates over use of fiber post when restoring ETTs, and they showed that through this in vitro study. So what they saw was there was catastrophic failure was seen every time there was a glass fiber post. And then the fiber reinforced post does not enhance the survival of all ceramic crowns. So there was no added benefit that was seen. Now, let's talk about the other scenario where ETTs with no ferrule. Do ETTs with no ferrule need a post then? Because if ferrule is present, then the post did not categorically give any added benefit. So do we need a post if the ferrule is lost? So again, another paper in JPD that talks about fatigue and failure analysis of ETTs without a ferrule. And then in this paper, this is how they check the failure modes of the dowel group, without dowel group, and the incisor view. So the conclusion was the use of a glass fiber dowel did not enhance the survival of ETTs restored with bonded lithium disilicate crowns over composite resin foundation restorations. Again, the limitation is this was an in vitro study, but you see the results clearly that less catastrophic failures were found in composite resin foundation restorations without dowels, no ferrule, while the use of dowels was associated with 100% catastrophic root fractures. And the picture speaks for itself. Then the last paper I'm going to talk about today is the clinical evidence on endocrowns, another good study that showed estimated survival rates of 98% at 10 years. And this was a retrospective study of documented endocrown cases. And then this is how they had the design of the restoration. So I cannot use my cursor for some reason, but you can see the picture speaks for itself. And the last slide for today is, so the advances in adhesive dentistry and the paradigm shift that we have been seeing over the last a decade or so, postless approaches and restoring ETTs with ferrule are becoming common every day. And the present data support the use of IDS procedures, and we can talk about IDS in our future talks as well, and the evidence around it. And this could also contribute to the high success rate in terms of debonding. So that concludes my presentation.
I think for a second we need to add a little bit more definition to the ferrule, and maybe you did because you threw a lot of information out there. As defined, the ferrule is essentially a band that supports externally some structure. Okay. In the old days, in that zoom right there that you have, where your mouse is going right there, the post is acting as a ferrule too. So the authors or the diagram bevels the edge of the dentin to get a ferrule effect on the cross-hatched post that you have right there. Yes. But and I'm not sure you explained this, the crown actually acts as a ferrule too, or the restoration acts as a ferrule if it's prepped beyond the edge of where the fractured tooth is. Did you discuss that or cover that?
I did not.
Okay. No. So what my contention would be, and I've heard other speakers do this, and I don't know that this is fundamentally been tested, but logically it makes sense, that if you're going to prep like that slide shows, okay, that you don't need to bevel the tooth with the metal post or the ceramic post or the composite post. That tooth structure could theoretically be saved. And it's, if you saw Martinoff and Sorensen study from a few years ago when they went and looked at, went into dental offices, looked at success and failure, looked in the charts. They didn't actually see the patients, but the teeth that appeared to have more remaining dentin was one of the keys for success, long-term success of an endodontic treated tooth. So my thought process is I wouldn't be beveling the external of the dentin. I would be looking at the restoration as a part of the of the that would create some ferrule effect or some grab. Let's think that's a micromechanical retention that helps resist in lateral stresses. So you other two gentlemen out there, why don't you jump in and give a little thought on so far what you've heard?
Well, I'll jump in because I'm in Southern California and I've been following. I haven't placed a post. We'd have to go back into the early 90s because Bogan and Charlie Cox and all these guys were some of the early influencers of us on this whole philosophy. So what I can say in clinical practice, it works. And the key being and I think now Pascal's talking about, we would always kind of shoot for 3 millimeter ferrule. Mm-hmm. And if you have a 3 millimeter ferrule, you're pretty golden. And so the argument would become use the post to support material.
Yeah.
Well, if you really want to do that, then just take some carbon fiber, some Ribon or whatever. Mm-hmm. But even that, you kind of then wonder, well, is that contraindicated too? Because when that carbon fiber becomes loaded with resin, it becomes stiff. So that does it now act as a fracture potential. So for me personally, since it's before 2000, it's in the later 90s, I have not placed a post. I think the last post I had was Snow Post from Danville.
Yeah.
And have not posted. I haven't put one in and have seen things last a long time. So this kind of discussion for me is it's just like...
I'm on a similar thought process as you, and Dr. Ortiz will let you jump in a second. Being involved with Sorensen over the years, he was jokingly referred to as the first prosthodonticist by Ray Bertolotti because he was one of the early adopters of adhesion as a prosthodontist, okay? And he did some studies with Empress, clinical study, endocrowns that I was part of when at UCLA, but it was really his study. And he followed close to 40 restorations where he just did a 2 millimeter internal engaging the canal with Empress, the original lower strength material, and then just restored the top of the tooth and then a little bit of ferrule, or wrap around the outside. And God, I think at 5 years there was 0 failures. So
I remember when Bertolotti presented that piece of research. So clearly,
we overuse post. One slide maybe we should go to that would help, I think, all of us with this discussion. Anvita, when you were talking about Dr. Magnier's research, Pascal's research, you showed let's scroll down. There was a slide where you showed something like that. There was actually some fracture even. Yeah.
Wait, hold on.
Yeah.
This
similar, yeah, there. Okay. Yeah. We're back one. Okay. The one you just clicked just before that, even one right before that. Okay. That you just clicked on. Okay. Yes. Oh, yeah. There. Okay. So so Dal Group D, where you actually engaged the canal on top of that internal projection down into the canal space, not the root space. That my understanding is that from this data that had a much higher fracture potential than the one 100%. In the middle. Yeah, that has no post in there. Okay, and I can tell you that's been my experience over the years. And I think part of the reason is that what happens is when you place that post on the left, you end up just damaging too much tooth structure. I'm not so sure it's so much stress to the root because you were showing that the post actually fractured. Okay, I have not seen clinically, and love Dr. Ortiz, you to chime in here, don't mean to dominate. I have not seen clinically a tooth fail that had a fiber tooth post in it. I mean, where the root fractures. Certainly over the years, I think all of us have seen, like that image on the right where it's been a metal post or somebody opened up the canal space so large that there was so little tooth structure left. Dr. Ortiz, your thoughts on this, please.
My thoughts are a little bit different than most people. Coming all the way from residency, I haven't placed a post in 10 years either. There's something called, I was looking it up on my phone because I didn't remember exactly how it was, but there's something called survivorship bias. Have you guys heard about survivorship bias?
I've heard the term, but define it for us.
So survivorship bias was something that happened supposedly in World War II when they were trying to figure out how to make the planes, the bombers, and the fighters survive more. So every plane that came back to base, they will analyze all the damage that it had from the opposite side that were shooting at them. And they had all these holes all over the place, and some places have more holes than others. And so the engineers were thinking, well, maybe if we reinforce these parts of the plane, they will survive more. And there was a mathematician who could say, no. We have a problem here. These are the planes that came back that have these holes. And if we make decisions on the planes that came back, we're missing all the places that didn't come back. And maybe the places that are not holed out, the places that don't have hole in the place that came back, are the ones that got hit there and are the ones that went down. So we might have to reinforce the areas that are not damaged in the planes that came back. And that came back to be true. The ones who were shot in the engines did not make it back. The ones who were shot in the wheel came back. So you want to reinforce the wheel because you see holes and you don't see holes in the engine. To me, this entire thing about post can be explained by two things that are related to survivorship bias. One is that in the past, we did not have adhesion. That is clear. So we need a retention or resistance. And we saw failures. We saw fractures if we didn't have failures. However, if we are to go back in time, we're going to probably find the same thing that we find today. If you treat 7 to 8 patients a day, like a regular dentist will, for 4 or 5 days a week, you will definitely see less teeth fractures than those with caries. So caries are much more prominent than fractures. I'm talking about this kind of fracture, not the little cast fracture now. However, the fractures in our head seem much more catastrophic. They really caught our attention when the teeth fractures in half, and we remember that, and we kind of count in our head, but we didn't count the 4 times that on hygiene we told a patient that 4 patients that they have secondary decay and their restoration, and that we need to do something about it. That doesn't seem, it seems normal. Well, probably the diet, it's probably the flossing, it's probably all these things that lead to caries and then no restoration. To me, this idea that teeth fracture has a problem of survivorship bias. We see the fractures and we want to fix the fracture. We want to fix the problem of teeth fracture, especially the ones that have post in it. However, when we have a tooth that has a post and a crown and we see decay, we think that decay has nothing to do with the post, nothing to do with the crown, nothing to do with the restoration. It shows, teeth get decay. The other thing that has to do with post is the fact that it's easy to do research on post rather than to do research on fracture. We have it on the screen now. You put a tooth on a piece of epoxy, you push sideways and you see how it breaks. And you push it into the brakes and you see how it breaks. To me, it never made sense to cut a tooth more to make it stronger. It never made sense. We're not making anything more than what God made, if you want to talk religion.
Right.
We're not reinforcing anything. What
That's
we're doing
proved in the literature too. Actually, that's been proved. Yeah.
We're not reinforcing anything. So we've been fixated. We fix it. We're trying to prevent fractures that don't really happen. What happens is secondary decay. And secondary decay happens because the more you drill, the deeper you are, you're denting, and the deeper you are in cementum. Once you're in cementum, not even with the gauze of adhesion, you have any help. And this thing, anything that you're going to push sideways is going to put stresses on the adhesive layer or on the cement layer and you're going to get leakage and secondary decay. So I always understood the definition of a post. The definition of a post was to, as Anvita said, to hold the core. So the moment that I understood that retention and resistance are no longer needed is the moment that I understood that I didn't need a core ever again. And the moment I understood that I didn't need a core is the moment I understood I didn't need a post. And the moment I understood I didn't need a post, I started thinking about fracture, no fracture, what kind of post, how do I put it in, how do I prepare if I get a ferrule or not. Ferrule, if you don't have it, you don't have it. Deal with it. Because if you don't have a ferrule, usually you still have a tiny bit of enamel rimming around. And this idea that we're trying to prevent fracture by removing that little bit of enamel and making a 2-3 millimeter ferrule, and now you're indenting or cementum. Because you're trying to protect it from fracture, but then you're going to ignore that 5 years from now, 3 years from now, you get secondary decay. To me, it made no sense at all.
Right.
So I stopped using referrals, and I stopped using post, and I stopped using all of that when I understood that all I need to do is to reconstruct what I have. And if I have a hole because it's endodontically treated, I'm going to use the hole. I'm going to go in the hole as deep as I can, and I'm going to save as much enamel as I can. And that's the end of the story. To me, it's not as complex as we want to make it. What we should look at the mechanic of tooth fracture. To me, the number one problem in dentistry, or the number two problem in dentistry, as I said in previous episode, number one is access to care. Number two is secondary decay. And I see a strong correlation of people try to drill and drill and drill more enamel out of a tooth to protect it from supposed fractures that in reality don't happen as often as a secondary decay. And we do know that any enamel that you have, you want to keep it. So that's how my mind, pretty early out of residency, come out of this entire discussion of the fracture, the no fracture, the feral, the no feral. I don't need a post because I don't need a core. I don't need a core because I don't need retention resistant, and I don't need retention resistant because I have adhesion. End of story for me. That's how I always thought about it. But I see the survivorship bias on. We see the fracture, we freak out. We want to fix the fracture.
I'm gonna add a caveat to that whole thing. So in this whole discussion, my personal feeling, where the huge issue exists, and I'm going to take the devil's advocate on this, are two things. Number one, we need to reinvent the endodontists. And right now, I'm working with a couple of endodontists here at Loma Linda where their access openings are so small that I can't even think of getting composite down in there, leave alone a post. So
the amount of remaining tooth structure, like Dr. Ortiz said, it's the amount of remaining tooth structure. Save
correct. And so when we look at this, and general dentists are out there doing endos, people ask me why I don't do my endos. I go, because if an endodontist could do a 5-canal molar, and I have a hard time filling the access hole, if I can't do that, I don't belong doing an endo. Because of destruction of tooth structure. Number two, the other number two one is this. Sadly, there's a lot of insurance driven, and an insurance company will quickly pay $365 for you to drop a post in a hole. Bingo, that's just like that. But they won't pay you to go to the pains and the effort of preserving that little rim of enamel and preserving how you fill that hole. So I think we're driven two things, is the insurance industry to a doctor who's looking at a tooth and he goes, or she says, well, I got a crown, I got a post and a core, that adds another $400 onto my $1,400 crown. And I can throw an endo in there myself and I'll do the endo. And now we've just destroyed the tooth. So I'm a little bit jaded in that world.
My follow-up to that, which is, again, how we read... My follow-up to what you should say is this. Is the insurance pushing the doctor to do this, or is the doctor doing something that they shouldn't be doing?
The doctor is using the ability to use the insurance code to get paid the money. That's simply that.
So the doctor is being unethical.
I think both points can be true. Doctor is
in some cases, doctors
certainly they're not being current, but also they're driven by hey, this is what the insurance company will pay for. Okay,
right, but let's go further back than that. Even my alma mater, Loma Linda, they still have a lecture in that D3 year on post and cores, and I go AWOL when I'm over there, and I go, why are you even teaching this?
I can guarantee you most dental schools do. I can guarantee you that. I'm in a lot of dental schools.
Teach it here as well, and that's why when I'm on the clinic floor, a lot of the general faculties want to do a post, and then when the students approach faculties who are prosthodontists, we are like, no, I could have shown some radiographs that happen day to day, and you would be surprised at how much tooth structure the students end up destroying, because the whole idea is right here, because they get taught in the dental school, and some of the general practitioners are still practicing it, and then somehow we're not taking care of the tooth structure, and it's so redundant. We're destroying the tooth structure to place it.
So I don't think that the dentist is being unethical necessarily in their minds. They're only doing what they've been taught by their own bodies.
Exactly. And we are still teaching it. So until we change the paradigm of teaching, I don't think it's
Exactly.
solvable.
Well,
Should we accept?
let me bring this home for our audience out here, because remember, our audience is watching, trying to make a decisions here. So we've got 3 prosthodontists and one of the top adhesive dentists, general dentist, but does essentially mostly adhesive, all here that you're all watching today. And with, Dr. Young, about 30, 40 years experience of not doing posts and doing thousands of restorations, is not seeing failure. Dr. Ortiz mentioned, for 12 years, he hasn't done post, and same thing, not seeing failure. And then you can see what Dr. Maharishi said from this literature review, that it's somewhat equivocal, meaning no necessarily, maybe the meta-analysis doesn't show too much difference between the two, but all of us that have practiced see when we remove too much tooth structure, it clearly is a detriment to the tooth. So then, we need to bring it home to a point that if you believe and that you have reasonable enamel to bond to, reasonable tooth structure, save as much as possible. And what I'd like to do right now, let me maybe, and this really I think will help the audience. Let me share.
Are you seeing my screen right now? So this is what I try to teach my students.
Yeah.
This is the way, like from the Star Wars analogy.
From our Star Wars movie, yeah. So
yes.
let me share. Let me please share the screen up.
Are we the resistance?
We are the resistance, exactly.
We're the heretics. We were heretics back in the late 80s.
let me share the screen for a second. I like the term defect-driven preparation. That's a different way of saying the same thing, only take away the bad stuff, okay? So, I think all of us today, when we look at this, most dentists on earth would crown this tooth, all right? For me, and I've thought this way for a long time, you guys, and I still learn from both of you. So I appreciate everything that you all do, and that's why I have you guys on here. Today, if it was my tooth, I think it's maybe folly to try and save this little teeny tiny thing right here, that mesiolingual cusp, but these buccal cusp are in great shape. We just had a little decalcification there, and they threw a little composite in here. And learning from my good friend, Dr. Ortiz, who's online, we machined something out, and then we finish it, and we end up with a very nice restoration. Those 2 cusps are going to do fine, as long as we don't do some sort of a balancing problem on top of them. I didn't want to show that right there. Let me back out. Okay, so I'm talking more along the lines of, and we'll get into this later about talking about saving a cusp, but I want to show what I'm talking about right here. That'll be maybe a future topic right there. So this is a very typical thing that we see, right? That somebody's had a root canal, and the reason for treatment, basically, the late girl was going to get married, and she had a large, gigantic smile that you could see her tonsils, basically, and the photographer told her to get some treatment. So this is kind of a perfect case where the root canal is fine. I should have thrown in the radiograph. Everything looks fine, but we got very small, spindly roots. So my belief is to take out, we're going to take out the bad stuff. We're going to take out the amalgam and caries. I don't like to leave caries in teeth. I know there's some literature that says that maybe it's going to be possible. Then from there, the simple thing to do is just look around for what's undermined, what's fractured, what you see is problematic, and there has to be some clinical judgment here, because we don't have a study to show what happens if we restore this, okay? But we know over time, if we see fractures going down buccal or lingual, we're probably going to lose a little piece of this tooth structure. But to draw attention to this, and I agree with Dr. Ortiz here, we have a very good distal marginal ridge here that's got dentin support. And for me, honestly, what I look for to save a cusp, and this will be a whole topic, we'll talk about it later, is do I have dentin support? Yeah, decent dentin support. It doesn't matter to me how thick it is. It can't be too thin, obviously, paper thin, but if we have some dentin support here, maybe a 1/2 or 1 millimeter dentin support, and I don't see the cusp all fractured up, I'm going to go ahead and save it. So my next thought process is I just take away the bad tooth structure. I prep down until I get to reasonable tooth structure, so I have a minimum thickness of my ceramic, 1.5 millimeters, okay? And then I stop, and then I look around and see what else is still happening. All right, we removed some of the stuff out of the canal and exposed these the root canals, the gutta percha right there. Now, I apologize for not putting in the radiograph, but the roots were very spindly. They're very curved. They're not real straight roots. So I was very worried about putting in a post in this when I can engage this space, and I'm not even sure we need to do that, to tell you the truth. So the only rest of it is to look around. We had some interproximal caries here, so I'm going to drop this margin down below the contact as long as we keep it in enamel. I have to agree with Dr. Ortiz. My preference is I'm going to try and save a marginal ridge if I can. I mean, there'd be two reasons that I might not save a marginal ridge, and we can certainly debate this. I mean, if there's a lot of interproximal caries on the adjacent teeth and you're worried about, you might want to extend a little bit for that, even though we didn't like that word. We extend to save, I guess not for prevention. And also, too, if I could keep the margin in enamel, if I could drop this down, but I chose to save it. So I can tell you experience over the years, and again, experience is anecdotal, but it still has some value. And I agree wholeheartedly with what Dr. Ortiz said. As long as we've got a periphery of enamel, save it. This periphery of enamel alone will cause virtually 100% success to the restoration. And so that I think is what the literature is basically showing, and I think what you all have been saying is that let's save that rim of enamel. Okay, let's make sure we have at least a minimum thickness of our restoration. Let's take out the diseased tooth structure, or at least most of it, and any fractures. And the only thing I would like to say about a fracture, I agree with you guys too. I think where the big mistake that people make, where were we on this, looking at a fracture here? So this is a large old amalgam that I removed, and you can see some caries here. Most people would jump in and just take all of that out. I agree with you. I know Dr. Ortiz talked about this last time. The only thing that I'm gonna be thinking about, I'm gonna take out obvious disease. And when I see the obvious disease stop, let's say movement and or leakage of tooth structure in either direction, I have no problem leaving these cracks in a tooth, because I believe the restoration, we can seal that, and then we can end up with something like this. And I have to tell you, as Anvita knows, and I mentioned to you all before, that we did over 3,000 restorations at UCLA, and we were tracking them real well. And over time, I believe we had one fail of bonded Emax restorations. Now, you never know people that didn't show back up, right? But the restorations we followed, and I think we followed close to 2,000 of them since 2005, with graduate students and me, bonded onlays on posterior teeth, and we saw one clinical failure. Our goal at some point was to do a retrospective analysis. That's a little trick you do in a university. If you do it retrospectively, you don't have to go through IRB. But unfortunately, a bad fire happened and closed our program down in 2017. So anyway, let's stop. Let's come back to everybody in the crowd, and maybe we'll finish up with some perspective on that. Do you guys agree, disagree? Do you what alterations would you do based on what I said? And I guess one thing would be nice to finish up, and let me just tell you one thing is there still maybe one small indication for a post? And yes. Let me just suggest for me when it would be, yeah, and I want your perspective. Okay, if I'm going to do a bridge, okay, and I got one abutment that's compromised, but I think it will survive and support a bridge. I'm probably going to do a little bit of a post and a core, maybe only go down the canal 2 or 3 millimeters like Dan Nathanson used to teach, do a composite buildup. So we just get some lateral stability, but still take advantage of adhesion. That would be my only reason for doing a post and a core today. And the post would be very small. And the goal would be to just maybe engage 2 millimeters of the canal and do some bonding. So I'll shut up and let the other experts in the panel share their perspectives on this. Dr. Ortiz, Dr. Ortiz, you go.
Indications for a post. The tooth is to be extracted pretty soon, and I need to temporize it. I can put a post on.
Okay.
The other one is the patient is over 95 years old, and I need to make that tooth go to the grave. A little bit of decay in 3 years is not a big deal. Let's put a post on it. So as it debonds and is micro moving, I don't care. I just want that thing locked in there. You know when it's locked in there?
Right.
Those are the true indications for a post that I have.
Okay. All right. So not too dissimilar. I might extend that a little bit if I thought the tooth might be salvageable and just to get a little lateral resistance. Okay, Dr. Young, you want to share your thought process? You said you haven't done one. Maybe you never. Maybe you don't do bridges.
No, I have a couple cases that I can bring up. I'm not going to, but I just basically believe if they're 96, 7 years old and it's broken off at the gum line, if I can get a 3 millimeter ferrule, I'm using Carrari's newest universal flow that's got like an 86% fill. I'm just going to blow it. I have images in my lectures now showing it. And where it was, there's no logic in why these should last as long as they have, but they have. And I think the secret to it all is you either put it in compression or you put it in tension. And really what we're trying to do is keep a tooth in compression, because the minute we get into tension, we start getting into the fracturing issue.
Right.
So that's kind of what you're doing when you're doing all this. That's
similar what Dr. Ortiz. That actually echoes what Dr. Ortiz said. Basically, he said that as long as he could get some ferrule, some grab, some adhesion, that he's going to opt for saving the tooth. It's just a pure...
3 millimeters isn't as big as you think it is. I mean, it's,
right.
If it's enamel, I'm not going to take the enamel. I'll keep the enamel because I can bond to that. I'll maybe ferrule if I'm down to that.
I think we got Dr. Anvita, who your quick thought process, and then I think let's answer a couple of quick questions, and then we'll wrap. Okay, guys?
Yeah, so just to wrap it up, I think you all brought a lot of great points, and I think this is a nice segue to move into the next topic for our podcast, which should be defect-driven presentations or onlay preps. And we can also kind of build-ups, yes, and also we can also rant about how there is no standardization of onlay preps, and that's a common question I do get asked in dental school environment, because not every prep is the same, but that's the nature of these restorations.
Right? Isn't that a good thing?
Well, that's the art form of understanding.
Yes. So it's
we don't want a standard prep, right?
Yes.
We don't want a standard.
You cannot have a standard prep. Yes.
You're free flow. You have to understand the concepts, the principles, and then you create.
And actually, Dr. Ortiz was co-author on a paper that was very extensive on preparation design. So let's review that next time.
Yes.
We'll get into that. All right, well, that wraps that segment. We had only like 3 questions this time, and that's actually probably pretty good that we only cover 2 or 3. Let me bring those up real fast, okay? And
great job, Anvita. That was a great presentation.
That was great, okay.
Sorry, it was a lot, but yeah.
No,
lot of compliments.
Take the compliment.
Thank you.
We'll start with the question number 2 that Dr. Ortiz, you handle first, okay? When you design your reconstructions, and let's say you're building teeth back up with guidance with veneers, do you restore guidance with veneers? And we probably need to qualify, there's different types of materials. You do veneer out of feldspathic, that's going to behave very different than if you make it out of Emax or even something like enamic, okay? So what's your thought process on that?
If we describe a veneer as something that we put on the facial side of the tooth and maybe a millimeter, a little bit extending on the incisal, no, I will not restore my guidance or change my guidance or have the veneers right at the end of this protrusive movement or even laterals. If we describe veneers as something that you can put on the lingual side of a tooth, when we talked in previous episodes as tacos or lingual veneers of U1, then yes, you can do composite, you can do a lingual veneer, you can do a taco preparation, all these things. I personally will not allow a veneer on the facial of a tooth that extend maybe a little bit over the incisal should then ride and fully change the guidance of my occlusal scheme. I will attempt to do something to the canons, maybe on the lingual with composite, or I will put composite on the lingual of the anteriors before I let them ride on porcelain veneers or on the edge of porcelain veneers. I think you're asking for trouble.
Okay. Dr. Young, your thoughts?
I kind of go with Miguel on that one as well, because, it's as much as a pain it is sometimes, it's doing the lingual composite veneers, the technique that's been described for many years. But creating your guidance. But if I'm going to do guidance, it better shoot over enough that
Yeah.
the majority of the guidance has been created.
Well, okay, so we could use a bunch of graphics for this. Let's say that you've got intact linguals, okay? You've gotten a nice, almost, centric style, just barely missing, which we would typically do with our anterior teeth, okay? But you just got a little bit of wear on cusp tips and a little aesthetic concern, so you're going to, primary aesthetics, but you'd like to get a little improved the canine guidance. Would that change your thought process? Because going back to our theme of how we started this, that we want to save tooth structure.
Yeah, and I definitely, maybe where I would differ, after 40 years of doing veneers, even with felspathics, it depends on the patient and what kind of, are they crux or whatever, but there's plenty of my cases where their last little bit of guidance was coming off of the edge of that porcelain.
Right.
So I don't know. I think it's a case-by-case decision.
Yeah.
Usually, if we're trying to change the guidances because we're seeing a problem with the ones that we have. And usually, the problem that the one that we have is you see the classic tip of the cuspid that are worn even into a negative C shape, right?
Yeah.
The classic you see the bottom one going.
Yeah.
I would never attempt to fill that with porcelain and tell the patient, "Go, you're good to go have fun," and don't understand that the system wants to do something. And the system is telling you how this enamel has been worn over 30, 40 years. And as good as bonding is and as good as the porcelain restoration is, or whatever restoration you put in, to expect that material is not going to suffer the same way that the tooth suffered before, I think it's a little bit foolish.
Yeah,
so I prefer in that situation
but okay, so
the entire lingual guide without
So in those cases,
composite, so write it all the way out, not just at the tip.
so in those
okay,
cases,
so
one of the
you'd
things,
restore the lingual incisal ledge and a little bit of the lingual with composite. What would you do on the
Yes,
facial?
I let her write all in composite and then eventually become ceramic.
but on the flip side of that, the other
Well,
thing
wait, Richard. Let me have him clarify that, because the audience, I'm unclear, so I'm sure the audience would be unclear. Okay, so you've built up a little bit on the lingual to a little bit of erosion, lingual incisal or lingual cusp tip. You build up the cusp tip a little bit. You got your guidance. What does your prep now look like on the facial? Let's assume you're not a broken down tooth, but maybe you want to change the shape a little bit, change the aesthetics.
prep into the composite, right?
So a couple of things. Let's define a couple of things. I'm very good at imagining what I'm saying, but I understand that a lot of people are not. Like, I can see things in the air, but not every brain works like that. So I'm talking about the cuspid that is completely worn out. It used to be like this, and it's worn out the opposite. And you can see as you slide that it's the lower cuspid that did, right?
Yeah.
So in that case, I say I have to put a veneer. I will do a normal veneer preparation. We can discuss veneer preparation, but I already can picture a facial normal veneer preparation.
Right.
And assuming that on my centric relationship, I'm not biting in the tip, that my lower cuspid is almost at the bottom of the cingulum, right here.
Right.
And then I have some room right here, right? This is my upper cuspid. This is the facial, this is the lingual. If my bite is here, there's not much I can do. I cannot change anything because I'm going to open the bite if I do that. But if my bite is here and the patient rides laterally a lot, I can put some composite here, and then my veneer is here. And then that composite will ride all the way out, and then it will go all the way to the porcelain, and it will go away. So one way to do that is you do your bonding step, you put your composite there, you ask the patient to bite down, it's going to create a little hole right here on the composite, and then you cure that, and then you start working your way backwards, which is what we used to not do when we wax up, remember? You work your way backwards to use that hole that you have in your composite to form a guidance that doesn't lock the patient in, right? So now you try to not lock the patient in. I understand not a lot of people can visualize that. Maybe I can bring something next time around.
That would be good.
That's how I like. But I'm not always just at the tip.
Yeah.
One of the things that I have always followed in that concept, because I've always prescribed, I'd put in a fossa splint, which isn't just your average splint. I'm going to deliver with the veneer, as part of my veneer treatment, is a nighttime fossa splint. If you see that kind of heavy wear on a patient, then I'm going to protect my veneers at night. A fossa splint. And then I can, I reduce the risk greatly too, because a lot of that happens at nighttime.
Yeah, but a lot of times we don't get the patients to wear splints. I would say we're lucky to get about half.
Well, within K. Naoki's bill.
Yeah, there's a good point there. But that from the average general dentist out there is well, I have a little bit different tact. If my lingual is intact, okay, and I think I've got there's not I appreciate your point. If there's some loss of tooth structure there, I'm completely fine with that filling in with composite. But if it's just a matter of extending, a millimeter and a half to get a little bit of anterior guidance with porcelain veneers, I would guess, Richard, maybe you, okay, but I've done well over 10,000 veneers in my time, and I'm sure you've probably done close to that too. Unless we really diagnosed somebody as a bruxer, we didn't see that gigantic. Occasionally we'll see a little bit of chipping or a little piece of porcelain lost at the incisal edge, but it wasn't a gigantic problem. Okay. Now for bruxers today, that's a whole different animal. I'm just going to switch materials. I'm going to do something like Emax, monolithic Emax, well equilibrated. And honestly, we just see so little failure of that material, especially if we can bond to a periphery of enamel and something like that. So we're not too dissimilar. I think we're both in agreement, or all in agreement, that we save as much healthy tooth structure as possible. The question is how we spread stress a little bit.
Yeah.
Let me give me 2 minutes. If you give me 2 minutes, I have a case that I did that. If you guys keep talking. Let me find.
Okay. One thing, while he's finding his case and he's going to bring it up, and that'll be obviously a little better to see an illustration or a clinical case. One thing I want the audience to understand, because I hear a lot of people say, well, I'm going to do maybe group function because there might be a reason to do group function, but they say I'm going to spread stress better. It's going to be less stress if we spread lateral contact on teeth. And that actually is not true. And I can prove it to you with a simple example. It's basically what happens is as you start to load the periodontal ligament, okay, there's a negative or proprioceptive response into and I talked to neurologists about this, okay, that will only allow you to apply so much stress to one tooth, okay? Then when you start to recruit a second tooth, you can add more and more and more stress. I can prove this to you so simply. If you can put your jaw, any of you sitting in the audience, canine only my canines are touching, okay? Right now on my left side, I am clenching as hard as I possibly can on my canine. I can't go any harder. I can barely feel my masseter. Now I can put my jaw into group function. I'm touching all of my posterior teeth and my canine because I now have the ability to support more stress, more periodontal ligament support. I can completely contract my masseter. So what actually happens is you aren't actually spreading stress better, okay? It's allowing you to create more stress as each individual tooth contacts. All right, so a different thought process on how you design it. Maybe there's a periodontal involvement of the tooth. You might choose to put less stress laterally on some, or more stress. Okay? Did you find your presentation?
Yes, I did.
Okay, let's let him share the screen.
So long case, I did this case live. I remember I did this case prepping and delivering all this case with about 150 doctors watching via Zoom live. And when I put the temporaries on the veneers, I teach how to do the temporaries. I never do that because I usually deliver the same day, but that day I was going to show you how to temporize and tomorrow I was going to do the things. I had done all my bonding steps. And then I did the bisacral temporaries, and tomorrow when I needed to deliver, I couldn't because I bonded. So I had to re-prep right to it so that I could deliver my veneers. So I remember this case pretty well. What are you guys seeing, the entire thing?
Yeah, we're seeing
this case was a mess, and then I did some Invisalign. As you can see, the canines right there, they're not that good. Let's just make it quick. So what I did with this one, because I wanted to change the guidance, okay? Because I didn't like the guidance. Here's her going right, here's her going left. And as you can see, I'm gonna have troubles in the front. So let's keep on how I did all that. I mounted the case, and I don't wanna bore anybody. But as I did that on the mounting, then you can see a little bit, it's the same color as the model, the wax. I don't know if you can see the lower canine and the upper canine on both. There's a little bit of wax there, I don't know if you can see it. And then unfortunately, it's the same color. Yeah, I put wax on the lingual of the upper canines, and I put a little wax on the lower canines. And with those 2 little wax, I knew that when I delivered these 6 or 8 veneers in the facial of this patient, all I needed to do was a couple composite on the lingual, and I have a whole new guidance. And some people will argue that the guidance will wear off over time. That's part of recall. You can have this patient in, every 6 months or a year and say, hey, whenever we lose this guidance, I should teach you at it again. And doesn't require any extra, prepping. So by adding composite without prepping to the bottom and the top teeth, I can recreate the guidance. I don't need to prep more. And I assure that as she's doing lateral movements, she wasn't going to hit my upper veneers the way that I didn't want it. So this is how I deal with changing guidance. I don't write on my veneers. And the reason I don't write on my veneers is, let me show you another case.
Well, look, interject just some there. Go back to that slide. That's great point, okay? The point is there's 2 parts of the guidance. One is the cuss tip, okay, plus the lingual. So what what I'm hearing you say, you're doing the lingual with composite and the cuss tip with your restoration.
I'm doing the lingual with composite and the cuss tip with my restoration, correct? Okay. I'm gonna put.
We're 100% agreed. We're in 100%. That's where I misunderstood you before. I apologize. I misunderstood you. So that's a good clarification for the audience.
Yeah.
That's awesome.
Yeah.
Great.
So you're doing canine guidance on your restorations, and then you're building up your anterior coupling with your lingual composites, right?
Yeah.
I'm getting canine guidance with my restoration. I'm not getting canine guidance with my porcelain restoration. I'm getting canine guidance with my composite.
Are you uncoupling before it gets to the porcelain then? So they're not going to engage the porcelain at all?
Yes. He's getting the guidance.
That's a good point. So
at the last minute, you will get to the tip to tip, which is the porcelain.
Right.
So technically,
the writing, all the lingual, the one that gives you all the guidance that separates the anterior teeth all the way until the last minute when you get tip to tip, is on composite.
And the question that I have on that is with Ed, as he was showing with his cuspid, a lot of patients are still sitting on the edges of their cuspids, rubbing back and forth. And I don't know, like Ed said, I've seen thousands of veneers and not seen that.
Let me give you a teeny trick on that, okay? So the point is, so he's got the initial separation of the teeth with the composite. We get to the cusp tip now, and then we're worried about that, right? We're worried about a chipping or something like that. A little trick, and I learned this from John Sorensen a long time ago. The guy was amazing. He could have been an engineer. Maybe he was an engineer. He's got a PhD or 2 PhDs. So what he would have us do, and I agree with this, is he would just make sure that there was no just point-to-point contact, that we had essentially 2 lines contacting each other, an area, of contact. That would spread the stress. Since it was only 1 tooth, the tooth could only absorb so much stress. But that point, if you had too much stress on one point, then that could chip. So I would make a little bit broader area contact when it got to the cusp tip. That's just
let me show you this case, because this case might show the audience what I was trying to avoid.
Sure.
Why am I trying to change the guidance, right? So this is how the case came in. This person comes in with all composite, number 8 on the right, central incisor wards, and the other one. And I say, hey, let's do 2 veneers, right? So this is my preparation, okay? They're the preps, okay?
Yeah.
And then they're the veneers, okay? These are 2 of the most beautiful veneers that I've ever done. I've never been able to replicate how good these veneers look. Like, I'm not that good with ceramic. This was like, okay? I loved it. And I took pictures, and I took the time to document this case, and the patients go home, and then that happens.
Yeah.
Okay? Now, how long do you think that it took for that to happen?
Probably
7 hours.
Yeah.
7 hours.
Yeah.
Okay? So 7 hours. So then I came back, and I checked what I should have checked way before.
Right.
Okay? What happens when she's going laterally? What is the mouth doing?
Right.
Why did the composite that she had was breaking? This is my inexperience, right? That I think that I can save the world when I was earlier in my career. That I thought probably the one who did the composite before, composite break, let me put porcelain. No. I understood at this point, and this is one of the cases that made me understand that That was how it's going to break. Same here. Case cam from, like, the picture on the top is how the case cam. And I say, okay, you have a bunch of composite there. Let me do a veneer. That's my preparation. There's my veneer on the bottom. And then that's my prep. That's my veneer. Veneer on. And then the patient comes in the next day. Boom.
Yeah.
Okay. Now, in this case, I use this for, this is the lecture to teach, right? So in this case, cement is on the tooth, not on the veneer that broke. I did not have a problem on this one. It wasn't right and wrong. So I cannot blame the occlusion more than normal. Maybe it is. So even, as I go forward, I knew this is the case that I did after the other one. So I'm like, now I learned to check if I had interference in some protrusive or lateral movement. It still broke. I don't have an answer for it. We can discuss it. But this is what we're trying to avoid. Like when we're talking about cocaine and gases, we were trying to avoid this to happen. And how do we alter? Just to show people that.
So I think that was a good triage of how we would think about cuss tips. And obviously we have to control left, right, and forward to evenly spread a stress over a tooth. And I think you kind of corroborated the point that I made, that if we've got a tooth passing over a tooth, if only one spot touches versus the edge smoothly slides over, you're more likely to have a fracture, especially if it's feldspathic or composite. I have one quick question to answer that came through, and then we'll wrap it up, everybody, except, we got our interview still. That's right. Okay, that'll be the next segment. I got to ask, what happened with the long-term digital workflow with refractory dies? Most of you probably know that we were working on machinable refractory dies. We got to a point that kind of died because we need a special material for that, and we've been struggling finding a company that would be willing to invest in it. They just don't believe, like we believe, that refractory veneers are still a possibility. And honestly, we started that just before COVID. COVID killed a lot of things, and that's put that project on the back burner. And then the other side of that is that some of these materials have gotten so good, these monolithic materials, done properly, whether it be a Vita block or something like a Suprinity or something like an Emax, that the techniques have gotten so good that these materials are pretty much looking like layered porcelain. So the interest has somewhat died down.
And people want white teeth.
Yeah, and we're fighting that constantly, more and more and more and more and more and more and more. You look at, now that I start to see dentists do it significantly more than I did just even a couple of years ago, it just might not be a trend that we can stop. But anyway, all right. Well, thanks to the panel, and our next segment we'll finish up with that, and we'll finish up with our interview with Dr. Devigus from Switzerland here in a few minutes. Thanks, everybody. All right. Good morning out there in Cyberworld today. We have a great guest for our show. I think this is our fourth show now, called Dental Raves and Occasional Rants, with the concept of talking about some current topics in dentistry. But just as much fun to interview different people around the world, some personalities in dentistry, both clinicians and researchers, and also dental technologists to get a perspective on what's going on in the world today, dentally, and maybe a little bit of just what's going on in the world today, from where somebody's situated today. So we're so fortunate today to have somebody that's become a very good professional friend of mine. We're in a couple of groups together. Alessandro Devigus. Many of you probably already know him. Probably doesn't need introduction, but I'll go ahead and do it. He's been a professor at University of Zurich. He practices in Zurich, obviously, a high-end restorative, minimally invasive practice. And I've had a chance to learn a few things from him over the years. He's developed a passion for photography, not just in dentistry, but in general photography, portrait, landscape, still photography, desktop photography, macro photography, really every form of photography. And he's evolved that into really an amazing platform called Dental TV. And so we'll link in the show notes, and he can show us a little bit of it or talk about a little bit of it today. All the teaching he does, not just in photography, but it started out really in photography, educating people really on camera systems. He tests literally every new camera system that comes out. So he is probably, in fact, there's not even probably, he is the best resource in dentistry today for our particular needs for our intraoral imaging. He's evolved that even beyond that. To talk about how all of our imagery relates to social media, marketing, how to use social media. He tests lots of programs related to that, both that work on phones and also on your computer systems. So, Alessandro, why don't you say hello to the audience here, and then we'll get into it.
Wow, thank you for this amazing introduction. So I'm always like speechless. But it's a great pleasure, great honor speaking to you from one side of the ocean to the other side of the ocean, with a country in between or a continent in between. So you're getting up. I'm not about to sleep, but I just finished my work with my patients today, and I'm really happy to share some insights and some information from my passion. So beside being a dentist, a passionate dentist, you're right, I'm a passionate photographer, because one is the passion for photography, and the other thing is my passion for clinical documentation. So we have to be aware and to know that dental photography is like X-ray. So we have like two tools besides scanning. Let's say scanning is the third one, but we have three visual options to check our patients. So we look through our patients with X-rays, standard X-ray, 3D X-rays, whatever, and we look at our patients with photo, video, scanners, face scanners, whatever. Sure. And what I see over the last years is that there's a distortion in this clinical documentation that's going on. So I made like a provocative post a few months ago.
How do you mean distortion? I mean, so do you mean people manipulating the images is what I'm guessing?
Distortion in the sense, not recording the pure information.
Right.
Getting a diffused image, getting a softened image.
Okay.
I was like talking about, would you put a softbox on your X-ray machine?
No. And I've never really liked soft boxes. I can just tell you quickly what I would do, and then you can get into what you would do. To me, many of you probably know I do my own ceramics. I know you do, Alessandro, and it's very important to me, especially if I'm doing a single central or two centrals, to copy the surface reflection that I see on a tooth, okay? And that requires surface texture and polish to be correct, and the surface has differential polish. So if I don't see the surface correctly, I can't do that. And when you diffuse light, it changes surface reflection. It might be an aesthetic look, but then it becomes very difficult for someone to copy that then. I have to do that with my hands, essentially. And if I don't have an accurate image, like you say, an undistorted image, that's not possible to do. And so that has been one of my things that I have not liked to see either, to tell you the truth.
And what amazes me is that if you're talking to professors from university, even the teachers are now telling me, oh, we take all our clinical images with diffusers and softboxes.
Yeah.
So my question related to this is, why should we spend hours on textures, be it in ceramic, in composite, or whatever, if then we cannot show the result, or we cannot share the result, because with the diffuser it's all gone. So everything looks nice. I know this was a trend that was initiated several years ago by Inaki Gamborena and others. And the reason was, let's say, the diffused image, the softbox image was done especially by lab technicians to showcase their work. Let's say you have a crown on a white plaster, and there's too much reflections, and so they try to reduce the reflections to see the beauty of their work. But they try to really do it in a soft way and combining images. And this trend then jumped over to the dentistry and say, it's easy. How can you make your work look great? Just use a diffuser or a softbox and everything looks nice because you don't see the result anymore. So this is, when I was editor-in-chief of the International Journal of Aesthetic Dentistry, I always thought,
forgot about that too. Yeah.
No problem. But I don't have a problem if you send me diffused images because you like them better, or social media likes better this soft touch, this Hamilton style. Maybe remember the Hamilton, this blurry photographs of young girls where you didn't see all the details. If you like it, okay, but give me also the real picture with all the reflections that might not look good, but shows me what you have done. So you always should record both images. You can do is say, okay, I have a case where the reflections are too much. Let's put on the diffusers and take an additional image to maybe see more details, but not do one. And you know what I mean?
Yeah.
For me, it's a combination. It's a new way of taking pictures, but only in addition.
Yeah, and to other things that are, I think, contributory as much or more is one of the things you start to learn when people do that is that hides mistakes. Okay. And it sort of blends everything, so it does look good on social media, or maybe it does so-called look good in an article. The problem becomes in real life, right? Our patients don't exist on our screens, on our computers, or on our screens, LCD screens, or LED screens when we're lecturing. Okay, they exist in conversational distance with people, and this is where it loses something. Okay, now again, if you're doing 10 or 12 teeth, maybe not such a big deal. Okay. But if you're doing 1, 2, or 3 teeth, which we still do on patients, they don't always all want all of their veneers done. This is where it becomes a gigantic problem. And my practice kind of is a little bit heavy in that over the years, that I got more single centrals probably than the average person because of that. It just doesn't look right, Doc. Well, it didn't look right. 1, they didn't match the color. 2, they didn't match the shape. And 3, they didn't match the surface reflection. And you're right. If you don't have the right image, then you can't copy something. So we'll spend a little bit more time in photography in just a little bit, but I wanted to get a little bit more sense about you and about Zurich today and what's going on in Europe to start with the audience. So how did you get interested in dentistry? Did you have family members in it, or was just the type of kid that liked to fix little things and make model work and things like that?
I always wanted to become a journalist. And then when I was 18, so that's why I ended up also as editor-in-chief of the International Journal of Aesthetic Dentistry, so I could live one of my dreams that I had when I was younger. But at 8, when I had to make a decision, so I realized that becoming a good journalist, I had to go to Germany to study, because at that time when I was young, there was no university teaching professional, high quality.
Still a young man.
Yeah, okay. But and then two people from our class. So a boy and a girl from my class. They told me, well, the girl decided to study dentistry because her father was already a professor, a dental professor, and my friend, the best classmate, told me, I want to become a dentist and make money.
Okay.
And then I told, okay. He's a good buddy. Okay, dentistry is not so bad. Yeah. I also like to work with my hand, so I was like becoming a doctor was an option for sure. And then we started studying dentistry, and now of the 3, I'm the only dentist.
Okay, great.
And I finished my dental school, and during dental school, I had like my major episode that really had the biggest impact on my dental career. It was a lecture when I was a young student from Professor Merman. In 1985, in 1985, he presented to us the CEREC system. Yeah. It was like standing in front of us and telling us, imagine a machine, your patient, yourself, and all these 3 elements are working on the patient and creating something.
Yeah.
And the chairside, the term chairside
Chairside
dentistry
yeah.
was born in the sense of we all do chairside dentistry when we do a filling, but the chairside dentistry assisted by a computer was born in 1985.
Right.
And then in 1986, I received 5 inlays, small inlays, done with the prototype of the CEREC machine, and they are still in my mouth.
Well, you were at the very beginning.
So the virus took me over, and from that day, for me, it was clear whenever I open my own dental office, I will start doing CEREC restorations. And so I did.
Yeah. Yeah.
I started in 1919. I bought 2 CEREC 1 machines because everybody was asking, why are you buying 2 machines? And I said, look, if you're a professional car driver, if one car breaks, you need a second one because you don't know. So for me, it was like the safety backup. And I always had then 2 CEREC 2, 2 CEREC 3, 2 CEREC. So I ended up buying now, I think I bought 14 CEREC systems so far.
Wow.
I did 35,000 restorations. And I still love it. I still love it because the thing is, if you invest into technology, there's one thing. Technology can make you better, be it CAD/CAM, be it a microscope, be it whatever technology you're using, but you also have to become better.
Right.
I always make the comparison. The Formula 1 car is the best car in the world. But we cannot drive it. We are not able to drive it. If we sit in that car,
we die.
In the first curve, boom, out, or even we cannot start the engine. So we are really messed up totally with this too advanced technology in our hands. And this is also something that I sometimes feel. Why are dentists not using more technology in their dental office?
Right.
And I think beside the investment, one thing is also the fear of not being able to control the technology.
Right.
So
for sure.
missing out, what are the benefits? What can this technology help me with? Can I become better? Yes, but only if you improve yourself at the same time. So if you buy a microscope, you have to change the way you work to make the best out of using it. If you buy a CAD/CAM system, you have to train yourself, you have to adapt a lot of techniques, workflows in your dental office to make the best out of it and to become a master in using this technology. And so many people then say, or many dentists say, oh, I will take my poly impressions and my alginates and do this and do the old school thing because I learned that at dental school and this works.
Right. Yeah, to unpack a couple of those things, great. And so everybody out there that doesn't know this, maybe the younger dentists, CEREC actually started at a brainchild of Professor Morman at the University of Zurich. So it unrolled out of there in the idea in the early 1980s and hit the market maybe mid-1980s. And sound like you're one of the early adopters. And you make an outstanding point about technology that people don't understand, but specifically related to CEREC. CEREC requires you to use CEREC effectively, even today, as good as it is today, okay? You have to develop a new skill set, and you have to be a better dentist. It doesn't compensate for bad dentistry, okay? What it requires is you to do your job perfectly, which is a little bit different. There's obviously similarities between analog and digital, but there's differences too, that you have to understand the differences and how to develop the workflow to optimize those differences so you get the results that you've been getting. So that's fascinating. You did 30-some-odd thousand restorations. Have you published on any of those, or I'm sure you followed quite a bit of those? What have you found? Hopefully we do have some CEREC dentists, or certainly people that are considering it, because more and more people. What would be a couple of pearls maybe that you would say that were critical in your ability to be very successful with it?
It's interesting that, let's say, the first generation of ceramics, the feldspathic ceramic, still performs, I would say, the best. Yeah. The best if we look at all the aspects. So longevity, nice looking, nice optical integration. So for example, 12 years ago, I started also using anamic, this hybrid material, easier to mill, easier to work with the machine. You can use it in thinner dimensions. So I introduced this material as an add-on, as an addition to my portfolio, because most of the restorations, or let's say CEREC dentistry, is redentistry.
Right. Okay.
We're not, if you have a tooth with a cavity, at least in Switzerland, 95% of the cases you do just a direct composite filling.
Composite, yeah.
You don't do CEREC inlays, onlays, crowns, or veneers as a primary intervention. You do it to replace amalgam fillings in insufficient larger restorations. So the concept, the CEREC concept that I did that is volume based. The smaller the volume, the more likely you use composite. The larger the volume, the more you get advantages of using indirect or semi-indirect methods, where you avoid shrinkage, where you avoid a lot of shortcomings composite, even modern composites still have. So this is a combination of thinking about or knowing the materials you use. So this is also a message. Don't think the best material is the latest material or whatever.
Yeah.
So we all know, for me, still, let's say, although it's a dying race, doing hand layer, feldspathic, platinum foil veneers, or whatever.
But they still look great.
Yeah, they look great. But the main message is learn to and know the materials you use. It's the same with technology. Go to the basics. You should know how the basic materials you are using perform, work. And if you know that, it's much easier, much less stressful.
And so we could make love for you to make a couple general recommendations, since you've done over 30,000 restorations, excuse me. And I'm going to come back to that feldspathic in just a second. Maybe the audience doesn't quite understand that. But where would you use enamic today versus like a Vita block or an Empress cat, which is it's just a feldspathic block? In fact, let me just deal with that. For the audience out there, I think everybody on Dental Earth has heard of lithium disilicate, specifically Emax, okay? A very high-strength glass ceramic. The original glass ceramics were actually blocks based on a feldspathic-type glass with some lucite crystals, kind of like porcelain, but in a block. And those are beautiful, and they're still working well today. And I couldn't agree with you more. If it's done correctly, bonded correctly, designed correctly, control the occlusion, I don't see really any necessarily clinical difference fracture-wise. But aesthetics-wise, they do have a definite improvement because the optics are very similar to enamel. So couldn't agree with you more on that. But share with where you might choose one or the other type of material.
Oh, enamic, and the rays of enamic is also related to the rays of more abrasion cases, erosion cases coming that just, they always have been there, but the number has increased dramatically over the last decades. And
that's where you'd use it. You'd use it more. You'd use it more in wear cases. Okay.
Yes. No, because I always tell people, they're arguing, oh, this material abrades much faster, blah, blah, and so on. Yes, that might be. But abrasion of material is a very complex thing that it cannot just be measured in a chewing simulator. The human body, you can do the same restoration in 10 different patients, and you will see different patterns, how they abrade, erode, because it's not only the pure force strength data. It's like somebody told me, the ideal patient is a female Japanese. If you put the restoration in a female Japanese, she doesn't chew very hard. She's a very tiny, very let's say slim person with less bite forces, so the materials will last much longer in this person than in another person. But coming back to this, I always tell people, how do you treat a Bruxer? You give him something that is not too hard. We are working with splints made of composite
plastic, basically.
Plastic. Okay. So think about replacing the splint with your restorations.
Right. Okay.
In the beginning, now it's a little bit better, but in the beginning, when I switched from feldspathic to enamic in certain cases, the patients realized the difference in biting on it.
Yeah.
They were like telling me, "Oh, doctor, this feels softer."
Yeah.
You know?
Well, let me. That makes great sense to me. Maybe you're motivating me to try it a little bit more. We're later on today. Miguel Ortiz is going to be on, and we are going to talk about that. He loves enamic, by the way. Where have you seen problems with it? Then have you seen excessive wear? If you're putting in Brexer cases, that would obviously be one thing you would be looking for. Have you seen problems with that, or problems with maintaining polish? Has that been an issue?
Well, the enamic, and Miguel will also talk about that. The major thing is you have to treat it right in the beginning. From the beginning, you have to polish it more accurately. Treat it like an extra special composite. And composite materials over time have shown that they are resistant. They lose their glossy shine over time, but the patients always have saliva on the tooth surface. They're not walking around and drying their tooth surface to show you, look, doctor, this surface is not shining anymore. But that's a fact. You can repolish them if needed. It's interesting that also there we see differences in patients. Some patients are really polishing their enamics and composites, just how they brush and clean their teeth. Others show more roughness because they are maybe more on an acidic diet or whatever. That has an impact also on these materials. But overall, I think if you make a good case selection, a good planning, establish a well-balanced occlusion, avoid premature contact. So the concept for me was from the beginning with CEREC was working on not always a pure canine guidance, but a group guidance.
Okay.
That I try to distribute the forces to as many teeth as possible.
Right. Okay. Great. So one of the things that you were mentioning when you were going down the list of materials, so that sounds like a great option, especially if you have, you're restoring occlusal surfaces, but you're trying not to build it up too much. You have minimal space, and you're maintaining the vertical at about the same level, but filling in the spaces there of wear. When would you maybe switch that thought process to restoring with lithium disilicate or potentially a feldspathic type material? I just tell you my thought quickly. I mean, if I'm opening the bite or restoring vertical, depending on how we want to define that, maybe a millimeter and a half on each tooth, then I'm going to do something like Emax, and I've actually been fairly successful with that, not seeing particular issues with fracture or anything like that. If it was Emax against Emax, let's say.
Well, basically, I left a little bit Emax because I don't like the extra step of putting it in the furnace.
Oh, okay. All right.
So, and then for me, the result, even using feldspathic, if you bond it correctly, if you have a uniform shell bonded on a tooth, then it's not an issue. The problem problem arises if you have irregular preparations. With differences in dimensions of the restoration over the tooth surface. Right. But if you have like a shell, so the discussion or the thing is, you can use like immediate dentin sealing, you can seal defects on a tooth surface in order to create at the end a let's say almost uniform shell covering the tooth surface.
Right.
And if you have a uniform shell that is 1 millimeter, 1.2, 1.5 millimeter uniformly around the crown and bond it on this surface. And it's
I mean, even if we look at Pascal's work over the years, where he did onlays out of layered feldspathic porcelain, which is the weakest material out there, and I think he reported on 50 or 60 over the years for several years. And really only one of them fractured, and he was able to rebond the pieces, as I remember. So that tells you even very, very weak materials bonded correctly do phenomenal over time. So if we have better, more resistant materials to fracture, or better wear resistance or a little bit of flexibility in the material, they should do great bonded well. And that's a good message to get out there to people. Great.
I think the bonding is the most important part in what we are doing. And you as a lab technician, layering feldspathic ceramic on PFM crowns, that's a very weak material, but bonded properly on the metal substrate, on the gold substrate, works.
Yeah, it's what I know you knew John McLaren, very famous dentist that knew Peter Scherer very well. I mean, the icons that we all learn from, right? That most of their stuff is still relevant today. He talked about a concept called a constant strain system, and meaning when you layer two structures together and they're bonded very well, the stress distribution is significantly better, number one, okay? It's not just holding the restoration on, it's spreading stress from occlusion, basically. And that if you have a stiffer substrate, for instance, enamel and or metal and or whatever, that it's bonded to, it's much significantly harder to start a fracture if you have good bonding because of the stress distribution. So I can tell you my experience. I haven't done 35,000 restorations. I've done 3,000 or 4,000 Empress over the years, Emax over the years. We can lump all these together, and I can tell you that the failure rate is where I didn't bond well. I can just tell you that, and it wasn't high. I mean, I didn't have excessive bond, but I maybe cut a corner. I used an all-in-one adhesive. I believed what the manufacturer told me, that I could use a resin reinforced glass ionomer, and they just don't work well. You have to seal the dentin well. You have to attach well to the dentin and the restoration. So share with you another interesting thing on the other side of this. I don't know where are you at with zirconia today, but we're gonna be publishing some very interesting stuff pretty soon. We'll be talking about it in the rest of the show later. I honestly don't believe you can, with what we're doing today, can get a very effective bond to zirconia. I think we can get reasonable bond strength, but the most I got, I tested 5 or 6 different bonding agents, and I'll tell you a fun thing that I did was I wanted to know how much the pure bond strength was just from the MDP primer, because we're told how wonderful the MDP primer, the methoxy or whatever 10 long word. I got some zirconia specimens. I polished them. I cleaned them so they were perfect. Okay, I cleaned them with everything you could imagine. I used 4 different zirconia bonding agents. Okay, Z Prime Plus, Monobond Plus, Curari's Ceramic Primer Plus, and Scotch Bond Universal Plus. Guess what the average bond strength I got on all 4 of them? It was under 5 megapascals.
For me, zirconia, let's say where bonding is not perfect, zirconia is used as a replacement for larger restoration.
Yeah.
From my point of view, and it doesn't make sense to do zirconia veneers. A lot of things don't make sense because we have material that perform better
and
like
easier.
industry looking for the one material that does it all. And the one material that does it all does not exist. So basically, depending on the indication, there's a niche for zirconia, for the bridges, places to put it on implants. There are some indications where zirconia is my choice or should be the choice, or at least something you have to think about. And in other indications, go for feldspathic or go for anamic, go for lithium disilicate, or go just for composite. That there's not the magic material, the magic tool does not exist. And this gets me back to the point that you should study, that you should learn and know what material performs in what situations. It's like, I know some dentists, if the patient asks, "Doctor, you just cemented a crown. What material is this?" And the answer is, I have to ask my lab technician. You know what I mean?
Yeah, they don't even know what they use.
It's a ceramic crown. It's a ceramic crown.
Right.
What ceramic? You know what I mean? So this is This is the thing. This is the thing that
Yeah.
I have just my dog entered. We have a nice pug lady.
Well, I'll interject while you're saying that then. So basically, what he's saying, and I agree with it.
Sissy. This is Sissy.
Okay,
Sissy.
great. All right. So are you in the office or are you at home today?
I'm in the office because in the morning I bring our dog. During the week, she's like in a kindergarten for dogs.
Right. Okay. All right.
Playing with other dogs and.
So we'll summarize with that and move on to another topic. What I think you're saying and what I would agree with is that you basically don't adapt the clinical situation to the material. Whatever clinical situation is present, you look for the optimal restorative solution for that clinical situation, and too often we don't do that. So anyway, now tell me how you got involved in, and you've been a professor at the University of Zurich. You still teach there. God, you were editor of the Journal of Aesthetic and Restorative Dentistry. Wow, I mean, when do you sleep? So how did
basically
you get
a lot of people are asking me about my time management, and I think time management is the most critical thing in your whole life. Yeah, well, I have a very tight schedule, so I'm although being an Italian, I'm maybe this is the German part. So my father's from Italy, my mother's from Germany, and I have taken some German things to be on time to try, and also the Swiss part. Like my mission statement is Swiss quality with Italian style. Yeah. I was going to say, if I was going to live in a second country, it would be Italy. I just love Italy. There's just something that appeals to me, and I've taken some art classes there. To be respective of your time, we'll go with like 3, 4, 5 more minutes because I told you I'd keep it at 30 minutes, and it sounds like we're going to need to because you probably got something else scheduled in the next 5 minutes. So you were a professor at a university, you taught a whole bunch, and then you decided to move a little bit back more in the private space teaching, and you started this dental TV company. And make sure you get us that link because I want people to check that out, please. Honestly, I'm not fluffing this. He is the best. Alessandro is really your best resource for photography today, not just in learning how to do stuff, but also to learn about the equipment. And this stuff isn't cheap. We all know that. Okay, every time we're turning around, it's a $3,000, $4,000 camera, $2,000 lens, and how to use these programs. And he has all of that information. And he's got a website that you sign up for and courses you can sign up for, and they're not expensive. They're very, very fairly priced to cover the cost of basically his team. So when did you start that, by the way? So maybe we'll finish up with that. Share a couple of ideas. I started Dental TV 2 years ago. So the idea was there are many dental education platforms out on the market. So it was not about doing another one or copying other ones. What I saw is that if you browse all these dental education platforms, you see the same content all over the place. Basically, almost the same teachers, the same webinars, the same projects. At the end of most of the webinars, you got the information. Hi, I'm at McLaren, and if you want to learn the details, I have a private education center in California. Come and join me for my 3 weeks education workshop that is only $50,000. And at the end, you could have told me this in the beginning that you want to sell me your workshop. But I'm not angry with all these guys because if you are asked to be on all these platforms and present your knowledge or share your knowledge, what do you get? So basically, I'm not doing this. I was like saying there are so many things that not only the younger generation, but especially the younger generation do not learn at dental school. Yeah, it's photography, it's videography, it's social media, it's marketing, it's well-being, it's how to lead a team, how to train yourself, how to eat healthy. It's huge. And basically, I'm trying to just answer questions. So now I have 350 videos on Dental TV, and it's growing. Because every time I hear a question from someone on my Instagram, on other platforms, I try to record the answer of this and post it then on dental TV. So this is how the thing is growing. And I'm inviting people like you or anyone out there, instead of starting your YouTube channel, join Dental TV, and we publish, or I create a series with all your YouTube videos. And it's like the idea, the concept is together we are stronger. Basically, the issue I see in the dental community is that we have too many solo creators, solo entrepreneurs, and we are missing really out the community. Even if you think about all the academies around the globe, go to the American Academy, European Academy, whatever academy. You go there, you clap on each other's shoulders and saying, wow, Ed, you're such a cool guy. You know, you say, hey, Alessandro, you're even cooler. And then we leave. Monday morning, you're back in your office. I'm Monday morning back in my office. And somebody's asking, by the way, was Ed on the meeting? And I was like, who's Ed? You know, so basically, we meet each other, we have fun, we drink a beer, we enjoy the time, but it's not, for me, it's not like really friendship. Maybe there are some friendships going out of these things, don't get me wrong. But basically, you go there, you cheer up, and then you go back to your dental office. And this is what the majority is doing. So I always tell people, wake up, look what's happening around, what's happening outside your dental office, enjoy your life. And then we don't need all these people that are now lecturing about mental health, about suicide of dentists and whatever. I can't hear that. If you are passionate about something, I'm sure you can overcome all these problems that are around, not only in dentistry. So basically, but the major issue I see is that the dentist tends to close himself or herself in this cage called dental office and is not looking outside. And if you not look outside, you don't improve yourself, you don't communicate, you don't learn. And then if you stay there and at the level of your graduation 20 years later, you find yourself in a deep depression for sure.
Right. And that's a great point. I mean, what I like to tell young people, I've graduated hundreds of students like you have over the years, is, you know, the reasons for meetings is really for the friendship, for the fellowship, okay? And maybe to open up a new idea, to open your mind to some new concept, okay? But then you need to, now because the world's evolving with education and how we disseminate information, this is a great avenue, learning from somebody like you or learning from your platform. Because yes, it is a multidisciplinary platform, bringing lots of people together like me, and I'm going to do some content for you like we talked about. And then the other thing to remember for the audience out there is that all of us lecturers, okay, especially if we're invited to the big meeting, okay, we're showing our best cases. We're showing dental Disneyland, okay? Or, excuse my French, dental masturbation, okay? That is great stuff, but we don't get that all the time. We do our best to get that. So don't get depressed by that. That drives us to a little bit better in one case, a little bit better photograph. You know, they've asked, on touching on photograph, they asked some great photographer, I don't know if it was Ansel Adams or somebody like that, why his photographs are so good. He says, there's not. I just take 3,000 a day, and one or two of them come out pretty good. There's a good message in that you have to do a lot of practice to end up with the one good restoration, the one good photograph. All right, buddy. So maybe we'll wrap with that. Anything else that you'd like to add? Because we're a little bit over that 30 minutes I promised you. But that was great information. And one thing I'd like to ask is, what's going? Try to keep this short. What's going on in Europe today? What do you see different about Europe and maybe the rest of the world, and maybe specifically Switzerland and stuff like that? Dentistry,
what we see in Europe is a decrease in income of the dental community, and this is also a factor that helps to create more depression. So we have a shift from a male profession to a female profession.
Okay.
Nothing against female dentists, don't get me wrong, but the female dentist has a less working hours, because if a woman then decides to have also family, she's not able to work 100%. So there's a huge shift in dentistry that is very rapidly coming.
Yeah.
And we need to be aware of that.
Yeah.
And many things will change automatically. You know, the conferences will change, academies will change, everything will change, because the work-life balance looked from a female dentist is not, I want to have more fun. I want to have more time for my family. If you decide to have a family, and this is then the work, it's not work-life, it's work-family.
Right, exactly.
Thing, you know, and this makes a change. So my wife was staying at home with our 2 kids, and I was able to work as long as I wanted, as hard as I wanted. She supported me. She still supports me. Now our kids are adult. We have even a grandchild, but you know, it's 5 years old now. But you know, this is the thing. So that's a culture, that's a change in our society that we need to be aware of and face it.
On maybe a dental school perspective on that question, do you see, here's what we've seen in the United States, and just see, is what's happened in the United States is they've had to charge patients too much, I believe, for dentistry, okay? Because the schools making up deficiencies in income, that as the schools, I still teach quite a bit in schools, not full-time, but you know, courses here, there. I'm seeing kids graduate from school doing 5 restorations total. That's it. And, you know, a busy dentist will do 5 in a day. Some people we know will do 20 or 30 in a day, right? And to me, I mean, they're just not getting the experience to be competent. And when they graduate,
the level of education has also dropped. The level of practical manual education has dropped also in Europe because of some reforms that we had to increase the theoretical part of our education. But this then is the message to the young generation, or to the young doctors out there. If you have graduated, I would say education starts right away.
Absolutely.
If you go out of dental school, then your practical education starts. And that's, again, where Dental TV can help with the non-dental parts that are also having a huge impact and a growing impact on the overall, let's say, quality of life, quality of work, personal development. So these are the things. Don't stop. Don't think if you have this master degree in your hand that you are finished with your education.
Right.
It just started. It just started that day you went out of dental school. Your education just started.
And I can tell you, having done this almost 40 years now, and you have probably getting close to that too, I can tell you, you just see that. The young people that come out of school that start learning from people like you and start getting involved with study clubs and start, trying to find a way to incorporate a reasonable level of continuing education, end up doing better financially. It's not just the cost of doing it, it's also the reward of doing it. All right, buddy. Well, I'll let you wrap up with any last couple of things you want to share with the audience.
Okay. My last words are the words that I always see in all the interviews I have done during the pandemic. Be passionate about what you're doing, love what you're doing, and never stop learning, never start being curious. Let's say, as a man have an advantage over women. Men never get adult.
That's true.
Men always keep being a child. So we hear that from our wives, that you're still like a child. But
that's the same everywhere in the world.
But be curious like a child, and keep that many of us are losing this attitude, this thing of being curious, trying to learn, trying to explore. Keep that, and I'm sure your life will be much better.
Okay, that's a great way to finish. And I would like to thank Dr. Devigus coming to us today from Zurich, Switzerland. And that was beautiful. And thank you, everybody. And thanks for turning into this episode. And by the way, we'll get you a copy of this. So if you want to post it on your social media, and also please send us a couple of links so we can put in the show notes. Okay?
Cool.
All right. Signing off, everybody.
Take care and talk to you soon.
Thank you.